Hello, my name is Eileen Robertson. I'm presenting this paper on behalf of a team at Health Policy Analysis. This was a piece of work that was done for the Australian Government Department of Health to help them refine and develop approaches to health workforce demand and needs-based modelling. It was specifically looking at the medical workforce, but the methods that we use here could easily be applied to other workforce groups. When health service planners are modelling the current and future demand for healthcare services, they often estimate the current relationship between population characteristics such as age, sex, socioeconomic status, and health service usage. However, these utilisation-based models have been criticised because they can embed current patterns of provision and usage into the future. If there are inequities in service use, then these can be perpetuated unless some account is taken of the variation in supply of services. A needs-based approach to service or workforce planning, they're seen as potentially better ways of matching resources or services or workforce to population needs. These approaches are able to take more account of underlying morbidity and risk factor, but they do rely on having good measures of underlying need and being able to determine the right level of health service input that you need to match those needs or to meet those needs. This part of this project that we conducted was aiming to test some of those needs-based approaches and see whether we could come up with a way of making use of information about underlying disease or morbidity to estimate what future workforce needs would be. So how would we go about converting measures of health need into workforce requirements? More traditional utilisation-based approaches to modelling future demand would start with the population by age band and geography. Then the relationship between these age bands and service use would be estimated. The population would be projected forward and an estimate made of the future service requirements and in turn workforce needs. But we're interested here in building in some approach that takes account of health need, and so we're interested in estimates of disease prevalence or other measures of health status across different areas and over time. However, disease prevalence data isn't always available at a small area level. It may be available at a national level, but it's possible to derive an estimate at a small area level by using age-specific prevalence of a condition and applying that to the age breakdown at a local level. In that way, you can derive an estimate for a particular locality. In this case, we're looking at SA3s, and that would give you a measure of disease prevalence at that level. The next step is to work out what health service needs are based on that level of disease prevalence. Now that could be based on the level of the current service utilisation, so based on what the national picture tells us in relation to comparing disease prevalence with the service, the total national service available. Or it could be based on some more normative assessment of service need using information from the clinical literature, clinical guidelines, or using expert clinical opinion. In these cases, it might be based on some notion of an ideal level of service need, which may not match the level that's currently provided, and so you could end up with some gaps between what's deemed to be currently needed versus what's currently available, and that mismatch might not help in relation to trying to estimate future needs. So how would we go about converting some estimate of health need into medical workforce requirements? This is an example of applying the approach shown in the previous slide to the specialty of cardiology. And we start by assuming that the number of cardiologists across Australia is about right to meet the needs of the population with heart disease at the current time. So with a given level of prevalence of heart disease, in aggregate, the number of cardiologists is about right. We know the national prevalence rate for heart disease from survey data, so we can estimate the number of people with heart disease. And as shown in the table, this is about 1.2 million people. The National Workforce Survey provides information about how much time doctors spend in delivering hospital care versus MBS reimbursed activity. And this allows us to split the currently available number of cardiologists between the two settings. So we can make an estimate of the full-time equivalent number of cardiologists devoted to hospital care versus MBS activity. And we can then work out the number of hours per 1,000 people with heart disease per annum. We can then take that rate of hours per 1,000 people with heart disease and apply that to a SA3 level geography, where we've made an estimate of the prevalence of heart disease. So in the case that the example we show here, we've got a prevalence of heart disease of 4.29%, which is the equivalent of just over 2,500 people within a population of 61,000. And what this estimate tells us is that that particular area would require 46 cardiologist hours to meet the needs for services delivered through MBS activity, and just short of 50 cardiologist hours to meet the need for hospital services, and that's over the course of a year. We can then apply the population projections and make an estimate of what that will look like in future years. We could assume that disease prevalence remains at the current level, or we could make some assumptions about what's going to happen to future prevalence and then build that into the estimate of the future need for the workforce. And that might be based on some estimate or assessment of current risk factors and what that might how that might influence future prevalence. On the left-hand side, there's a screenshot of the input screen of an interface that we built using Shiny. It allows the user to input prevalence information of the sort that was described in the previous example. So overall, this needs-based approach could be used for some but not all specialties. Some diseases such as cancer are much more complex to map to different specialties. It's important to have some reference level to indicate sufficiency of service, and we need to also be able to take account for substitution between workforce groupings, how to take account of different service models. However, despite those sorts of issues, we do think that this is a useful approach that can be used to supplement the more standard utilisation-based approaches to modelling the workforce. Thank you.